I'd like to thank the organizers for inviting me to speak with you today. I'm going to discuss COVID-19 in pregnancy and the potential for mother-to-child SARS-CoV-2 transmission. I've got no conflicts to disclose. So I want to start by noting that data continue to be preliminary, some poor quality, change almost daily, and hence conclusions may change as more data are accrued. So first, let's address susceptibility in pregnancy. This is difficult to answer as most population studies do not provide pregnancy status for women. While initial data from the CDC did not suggest higher prevalence in pregnancy, some more recent data is of concern. In a study of universal pre-procedure SARS-CoV-2 PCR testing before all surgeries or deliveries in a St. Louis hospital, positivity rates were over 4 times higher among 532 OB compared to 5,011 surgical patients, 4.7 versus 0.3%. CDC reported that 9% of over 91,000 reproductive aged women with proven SARS-CoV-2 in the US were pregnant, which is higher than the 5% rate of pregnancy in reproductive aged women in the US. And data are currently insufficient to draw conclusions regarding pregnancy status and susceptibility to SARS-CoV-2. These are infection prevalence data on SARS-CoV-2 PCR from a systematic review of 26 studies, including over 11,000 hospitalized pregnant women. In studies with universal screening of all pregnant women, infection prevalence was 7%, and as might be expected, infection prevalence was higher, 18%, with symptom-based screening. Overall, there was a 10% prevalence of SARS-CoV-2 infection in hospitalized pregnant women in these pandemic locations, and all of the highest prevalence studies except one were from the US. This study looks at the prevalence of SARS-CoV-2 antibody among 372 pregnant women in the first trimester, 502 in the third trimester, at 3 hospitals in Barcelona, Spain. 125, 14% had antibody, indicating past infection. Seroprevalence was similar in pregnant women in the first and third trimester, 15 and 14%. However, symptomatic infection and hospitalization were significantly more frequent in infected women in the third trimester. If you look at the figure, asymptomatic infection in purple was seen in 70% of first trimester versus 52% of third trimester women, mild infection in green in 30% of first and 44% of third trimester, and pneumonia in orange was observed only in third trimester women. Consistent with this are data from a national population-based surveillance study in the United Kingdom involving over 194 maternity centers where testing was symptom-based. This slide shows you the gestational age at symptom onset among 427 pregnant women hospitalized with COVID-19. The majority of women, 73%, presented in the third trimester, and only 19% presented in the first or second trimester. 7% didn't have symptoms until labor or immediately postpartum, and 161 women, mostly the first and second trimester, were still pregnant after recovery. Studies in the UK and the US show a disproportionate rate of SARS-CoV-2 infection among pregnant women of color. In a study of universal RT-PCR testing at delivery in Chicago, compared to those with the negative PCR, positivity was more likely in Black and Latina women. In a study looking at SARS-CoV-2 IgM-IgG antibody positivity in over 1,200 pregnant women delivering in Philadelphia, there were higher rates of seropositivity in Hispanic and Black women, 10%, than white women, 2%. Finally, in a national cohort of 427 pregnant women admitted to the hospital with SARS-CoV-2 in the UK, 56% were Black or ethnic minorities. This disproportionate representation is due to sociodemographic data rather than racial features, and these are data from a cross-sectional evaluation of 434 pregnant women in New York City that were identified through universal screening, with 18% being positive. Linking testing results to demographic data, the probability of a positive result on the y-axis was significantly associated with lower median household income, higher unemployment rate, higher number of residents per residential unit, and having more than one person per room. So do symptoms differ in pregnant and non-pregnant women with COVID-19? And these are data from the CDC on over 8,200 pregnant and 83,000 non-pregnant women of reproductive age with lab-proven COVID-19. There were similar frequencies of cough and dyspnea, but pregnant women less frequently reported fever, myalgia, chills, headache, or diarrhea. A caveat here is that while pregnant women in labor may not present with fever, postpartum fever may be seen. Similar to what we now know about SARS-CoV-2 in the overall population, the majority of pregnant women with infection are actually asymptomatic. And these are data from 15 papers reporting on universal SARS-CoV-2 RT-PCR testing of over 10,000 pregnant women presenting in labor from the US and other countries, as shown. Overall, 348 or 3.4% had positive tests, and of these, 230, 66%, were asymptomatic in purple, while 34% were symptomatic, shown in yellow. Risk factors for hospitalization were examined in the UK population-based surveillance study. 427 pregnant women, 5% had confirmed infection, and you can see the incidence of hospitalization was significantly higher in pregnant women of Black race, older age, and higher BMI. Early data from systematic reviews in the CDC suggested that pregnant women had a similar disease course to non-pregnant adults. However, are all non-pregnant adults the correct comparison group? And we know that there's a significant relation of age with disease severity. And these data show that there are significantly lower rates of hospitalization, ICU admission, and mortality among the reproductive age group 20 to 44 years. And more recent studies have shown increased rates of hospitalization, ICU admission, and mechanical ventilation, but not mortality among pregnant women compared to age-matched non-pregnant controls. And these are data from the US. Compared to non-pregnant women with COVID-19, pregnant women had a 5.4-fold increased risk of hospitalization, 1.5-fold increased risk of ICU admission, and 1.7-fold increased risk of mechanical ventilation, but no increase in mortality. Older age was a risk factor for severity, with women aged 35 to 44 having the highest rates of these outcomes. Similar data were reported in a systematic review of 77 patients, including over 13,000 pregnant and over 83,000 non-pregnant women of reproductive age hospitalized with COVID-19. And here you see a 1.6-fold increase in ICU admission, 1.9-fold increase in mechanical ventilation, very similar to the CDC data. And again, no difference in mortality. And again, older age, high body mass, and pre-existing comorbidity were risk factors for severity in pregnancy. So is pregnancy outcome modified by COVID-19? The population-based surveillance study in the United Kingdom compared 427 women with confirmed COVID with a control cohort from a prior study of seasonal influenza in pregnancy in 2017 to 2018. Pregnancy loss or stillbirth were slightly but not significantly higher among pregnant women with COVID-19 than the controls. More women with COVID-19 had cesarean delivery, 60 versus 29%. And in 51%, this was due to maternal disease or fetal compromise. And more women had preterm delivery, 26 versus 8% without COVID-19. The majority of these were at more than 32 weeks gestational age. And again, most preterm deliveries were iatrogenic due to maternal disease severity and fetal compromise. Infant outcome was reported for 265 live-born infants in the study. 25% were admitted to the NICU compared to 5% of non-COVID-19 births. However, the vast majority of these admissions, 75%, were due to complications of prematurity. And there were 2 neonatal deaths. Both of them were due to prematurity and not directly related to COVID-19. So I'm going to spend the remainder of my time discussing the feasibility and limited data on potential mother-to-child transmission. So in utero infection requires that the placenta be able to reach and cross the placenta and to infect the fetus. However, SARS-CoV-2 viremia appears rare. In 8 studies, only 4% of samples had a positive PCR, and there was an increased likelihood of viremia with more severe disease. Both ACE2 and TMPRSS2 are found in the placenta, late gestation more than early, but co-expression may be minimal, although other cell surface protease inhibitors could substitute for TMPRSS2. And both of these receptors are found in the fetal lung, heart, and liver. Finally, placental disruption that could allow viral passage without placental infection may be possible due to SARS-CoV-2 related coagulopathy. And in one study, 10 of 20 placentas showed some evidence of vascular malperfusion or fetal vascular thrombosis. Does finding virus by PCR in the placenta always indicate infection of the fetus? So let's look at HIV. CD4 receptor is found in the placenta and the fetus, and we know that HIV can infect placental cells. However, the presence of HIV antigen in the placenta does not always correlate with infection of the infant. And this shows 2 studies. 19 placentas were positive for HIV by PCR, but only 5 had infected infants. And of the 48 placentas negative for HIV by PCR, 5 had infected infants. Thus, for HIV, definition of infant infection requires a confirmed positive PCR on infant blood samples. Various viruses have been detected by PCR in amniotic fluid of low-risk pregnancies without evidence of fetal disease. And this shows you a prospective study of low-risk women referred for amniocentesis, where PCR testing for a number of different viruses, as shown on the slide, was done. 6% were positive for 1 or more viruses, with adenovirus being most common. Pregnancy and perinatal outcomes did not differ between those with and without positive PCR, and positive PCR was not associated with evidence of fetal inflammation or infection by cytokine presence or with pregnancy loss. Thus, amniotic fluid detection of virus by PCR does not always mean fetal infection. Intrapartum transmission requires fetal or infant exposure to infectious blood or secretions during labor and delivery, and for that pathogen to be able to infect the newborn. However, SARS-CoV-2 is rarely found in vaginal fluid, only 3% of samples in 15 studies. But in contrast, SARS-CoV-2 is frequently found in feces, with more than 40% of infected individuals having a positive fecal PCR. Whether this is infectious or not is unclear. In 5 studies, viable virus was only able to be detected in 35% of 17 patients. The potential importance of environmental contamination in the delivery room is illustrated by this study of environmental sampling of room surfaces, air, and healthcare worker face shields in birth from 4 asymptomatic women who tested SARS-CoV-2 positive, 2 with a vaginal and 2 with cesarean deliveries. After delivery, 18% of surfaces, 22% of air samples were positive for SARS-CoV-2, and this was more with vaginal than cesarean delivery. Post-delivery face shields were positive in all healthcare workers with vaginal delivery, as shown, but none with cesarean birth. Finally, postnatal transmission requires infant exposure to infectious breast milk and for the infant to become infected via the oral or gastrointestinal route. SARS-CoV-2 has rarely been detected in breast milk. In 12 studies, 20 of 196 samples, 10%, from 10 of 85 women, 12%, had a positive PCR, and this was generally transient. It's unclear whether this is infectious virus. And in one study, no replication competent virus was detected in a breast milk sample positive by PCR. There are 2 cases of infants who were fed PCR positive breast milk who were uninfected, and 2 cases where the infant became infected during breastfeeding, but the mother was infected postpartum, so horizontal transmission cannot be excluded. There's been no documentation of SARS-CoV-2 infection via the oral route in anyone to date. And SARS-CoV-2 specific IgG, M, and A antibody have been detected in breast milk in several studies. However, whether this is protective is unknown. Now, there are 2 published proposed definitions for perinatal SARS-CoV-2 transmission. The SHA definition is pretty complex. It has 5 categories: confirmed, probable, possible, unlikely, not infected for both mother and infant, 4 infant classifications: congenital fetal death, congenital live birth, intrapartum, and postpartum, with further stratification by symptom status of the mother and infant, and maternal infection is assumed to occur near childbirth. The Bloomberg definition is more simplified, requiring maternal infection within 14 days to 2 days after birth, and the infant is either infected or not. Symptoms are not part of the classification, but persistence is important. They have 3 classifications: in utero, intrapartum, early postnatal combined, because it's hard to differentiate, and transient superficial infection, where the virus may be transiently detected up to 24 hours after birth in an infant without persistent detection that indicates actual infection. And the WHO is having an expert committee meet to better define criteria to define classification of timing of infant infection. The University of Birmingham Living Systematic Review evaluated 87 papers published through May 28th, including 869 exposed infants, 52 or 6% had suspect infection, 49 due to positive respiratory secretions, and 3 with SARS-CoV IgM and neonatal blood. However, there are major issues with most of these reports, including the timing of maternal test, not specifying sample type, time of infant testing, and lack of confirmatory placenta amniotic fluid and serologic testing. So I'll go through these data. Of 52 positive infants, 13 or 25% were born to a mother diagnosed postpartum, so it's likely that this was horizontal transmission given maternal contact. Of the remaining 39, 7 had vaginal delivery, which could result in infant contamination or in intrapartum transmission. If we look at the timing of specimen collection, 29 infants had their first test at age greater than 24 hours. So you can't rule out intrapartum or horizontal transmission. 20 had their first test at age less than 24 hours. 10 were negative on the first test and positive only later. And 10 were positive on the first test, but had no repeat test in 9. If we look at the 8 who had their first test at the most optimal time, less than 12 hours, 3 had vaginal delivery. There was no testing of neonatal blood, amniotic fluid, or placenta. One of the children was actually IgM negative. And in the one that had a repeat test, it was negative at 36 hours, and none of these infants had symptoms. In the 3 infants with IgM antibodies, all respiratory PCR tests of the infant were negative, and none had symptoms. If we look at detection in other tissue samples, there were 6 positive placentas reported, 1 in a second trimester miscarriage with PCR negative amniotic fluid, cord blood, and fetal tissue. And in the remaining cases, all infant respiratory tests were negative and none had symptoms. 1 possible case with positive amniotic fluid was reported. The infant had fever, but it resolved on antibiotics. Vaginal fluid and cord blood were negative, and no placental or IgM testing was done. The infant birth respiratory sample was negative, but then was positive at 24 hours. And one possible case with a positive cord blood and placenta was reported, but the infant had no symptoms and had multiple repeated negative respiratory PCR tests. So, what does this tell us about SARS-CoV-2 perinatal transmission? Well, most studies have not obtained appropriate specimens at appropriate times or confirmed persistence or immune response to the virus if it was present. And virologic data consistent with in utero infection was found in only 2 of the possible 52 cases in the analysis, but both were asymptomatic infants with negative respiratory samples. Since this analysis was done, we have one case of what I believe is true in utero infection. And this was a mother with severe illness with a positive PCR, not just in the NP swab, but also in blood and vaginal fluid. Amniotic fluid from an emergency C-section and placenta were positive by PCR, and the placenta showed signs of malperfusion. The preterm infant needed resuscitation and had blood and bronchoalveolar fluid that was positive, as well as repeated positive respiratory and rectal swabs. The infant also had transient neurologic symptoms with abnormal MRI. However, despite all of this, the infant improved and was discharged. So in summary, many questions remain regarding pregnancy and COVID-19. There are inconclusive data on whether pregnant women have increased susceptibility to infection. Pregnant women may be more likely to have severe disease than non-pregnant women of a similar age. And as in the overall population, severe disease is more common in pregnant women who are obese, older, or have underlying conditions. Severe COVID-19 in pregnancy may be associated with preterm delivery, and that's likely due to maternal disease and fetal distress. NICU admission appears more likely, but that's due to prematurity rather than symptoms of infant infection. Finally, the effects of maternal infection on the embryo and fetus are unclear. There were very few reports of first trimester infection, so the effects of early infection are unknown. Intrauterine infection, while it can occur, appears very rare. Peripartum transmission can occur, but also appears uncommon, and there are no proven cases of breast milk transmission. Finally, and reassuringly, overall, SARS-CoV-2 exposed infants appear to do very well. Thank you very much for your attention.